So let me welcome all of you. We have an amazing turnout to this webinar called Navigating Through Perinatal Loss, Psychological Outcomes and Factors Contributing to Growth. And it's so wonderful. I hope that some of you will note others that are here cross-disciplinary, because we really want to support in the organization cross-disciplinary fertilization growing with each other. So I am honored to present our speaker today. Dr. Agata Freedle is an assistant professor in the Department of Education, Sciences, and Professional Programs at University of Missouri, St. Louis. She holds a PhD in counselor education and supervision from University of Missouri, St. Louis, and an MA in clinical mental health counseling from Valparaiso University, and a bachelor's in science in psychology from University of Sterling. Dr. Freedle is a board-certified licensed professional counselor in the state of Missouri with a certificate in perinatal mental health. Her current research focuses on exploring the psychological impact of reproductive trauma and perinatal mental health concerns on families, as well as counselors' competency in supporting such families. Dr. Freedle is interested in developing evidence-based practices to support families with challenging reproductive narratives and to reduce disparities in care. Dr. Freedle has presented at many international and national conferences, and her work has been published in top-tier scientific journals such as Traumatology, Death Studies, Psychological Trauma, Research Policy and Practice, and Journal of Loss and Trauma. Dr. Freedle has been a PLIDA member since 2018 and has served on both the Diversity, Equity, and Inclusion and the Education Committees. I'm honored to welcome you to provide this very important information from your research and practice. So let's welcome you, Dr. Freedle. Go right ahead.
Thank you so much. Thank you so much for this wonderful introduction. I'm going to start sharing my screen, and so you can see my slides. Okay, perfect. So yes, thank you so much. I'm very excited to be here. And like Dr. Rich said, there's such a variety of professions that we have here today. So it's very exciting. And I hope that from this presentation, you each will get at least a little nugget of information or something maybe you didn't know, or something that can really help you in your practice or your understanding of how perinatal loss impacts individuals' mental health, not just in that acute right after it happens, but also longitudinally or within that first year or so after the loss takes place. So I do believe that how we understand the problem really determines our solution. So as we are going through this presentation, I'm going to share with you research findings from my studies that are kind of trying to help us better understand those nuances and mechanisms of change and growth in this population. All right, so as we're jumping in, I want to get us started with just talking about what is trauma, right? So making sure that we're all on the same page, since we are, again, coming from very different experiences and professional backgrounds. So one way of looking at trauma is we can define it by using the DSM diagnostic and statistical manual that we're using as psychologists or social workers, mental health professionals, to guide us to how we define trauma, because I feel like these days, word trauma has kind of been loosely thrown out there, right? You might have friends who will say like, oh my gosh, that was so traumatic, right? Probably was more stressful than traumatic, right? So trauma, by definition, is exposure to actual or threatened death, serious injury, or sexual violence that you either have to directly witness that event, witness it as it happened to other people, heard about the event, or having a repeated or extreme exposure. So we're thinking about like police officers or firefighters. right? So if you're thinking about perinatal loss, it really does fit in that criteria, right? You're most likely are experiencing somebody else's death, right? The death of a child, and potentially experiencing your own serious injury or your own potential for death, right? Depending on the circumstances of how everything unfolds. So that's just one definition. Other way we can look at it is looking at trauma as a stress response. So this one kind of helps us a little bit more in terms of understanding a little bit more of that nuance of how trauma happens. So again, stress is normal. We're all experiencing stress, especially now as we're nearing toward the end of the year, right? There's a lot happening in those last few months of the year. So stress is normal, right? And we need stress to do things, right? To motivate us to prepare or learn or study and things like that. But when the stress becomes so overwhelming and outside of our normal, what we normally would experience in our life to happen, has a potential to break down our self-regulatory functions. So we're no longer able to function in a way that we normally would as a result of this thing that happened to us, right? So our bodies will respond differently to those situations. So that's when we're talking about stress being traumatic, when it overwhelms our capacity to function and regulate our internal stress states. So where our field is moving right now is toward this more holistic trauma perspective. So not just looking at the event or biologically what happens, but also the diversity of experiences and diversity of the impacts and responses it has on the individual. So from this perspective, we're looking at range of traumatic experiences such as severity, types, duration, repetition, predictability of how it happens, what kind of impact it has. So not just, again, in that moment, but taking into account where that person is developmentally, how is it impacting them cognitively, emotionally, what is their psychosocial environment, right? So depending on your socioeconomic status, for example, the impact of trauma is going to be different because you're going to have access to different support systems and different resources around you, right? And then also how individuals might respond, right? So it might be through reactive complex responses, but also resilient responses and growth. So thinking about how those different responses impact social relationships, roles, and community participation. So to kind of more overall, like I said, holistic look at all those different nuances that can happen when somebody experiences perinatal loss. So again, I'm framing perinatal loss as traumatic event. It is absolutely a bereavement event as well, right? There's a death that we are grieving. But for the purpose of my research and this presentation, I'm really looking at it as a traumatic loss. So based on the definitions that I presented to you, this can happen in a lot of different stages or ways when working with this population. So starting with, how did you find out, right? How was this diagnosis communicated to you? How did you find out that your baby doesn't have a heartbeat anymore, right? How were you supported afterwards? What kind of supports were offered? Was it acknowledged as something that was traumatic that just happened? How was the birthing process, right? Again, depending on the management of perinatal loss, what were you offered? Did you have to wait a long time in order to get the D&C, for example, or were you given an option of C-section versus natural vaginal birth, or were you offered the same medications, right? How much control basically you had in that birthing process, and how much of a relational approach there was to manage that with you. And then overall, what were the interaction with healthcare professionals, but also other people? Again, what was said to you? How did they respond to your loss? How did they respond to your asking for help? And we know that it continues to be pretty stigmatized loss, right? People tend to, I mean, in general, people are uncomfortable with grief. That's just kind of how it is in our society, but very uncomfortable with this type of loss. So well-meaning supports might often say things that are just more isolating and feel more judgmental, right? So things like, oh, at least it wasn't a real baby before you had a loss, right? Or you didn't get a chance to attach to it too much yet before you had this loss. That it can exacerbate make this loss even more traumatic or exacerbate something that already was traumatic. So overall, understanding that trauma results in a fundamental reorganization of the way mind and brain manage perceptions. So it changes not only how we think, what we think, but also our very capacity to think. So that's a quote from Dr. Bessel van der Kolk, who was a big trauma researcher. But it basically clues us in that there's something profound that happened in that moment that changes, again, not just how we think, what we think, but just our capacity to be able to really reflect and find meaning in that very traumatic experience. So again, if you're a clinician, you're probably familiar with the key features of post-traumatic stress. But when we're talking about post-traumatic stress, what we're talking about are all those different symptoms that we might see in somebody who experienced trauma or loss like that. So we see intrusive thoughts. So there would be recurrent, involuntary thoughts, distressive dreams, dissociation, meaning kind of being checked out, right? Kind of disconnecting from your environment, and not in a planned way, or more in a way to kind of protect yourself from further harm. Just high levels of distress, avoidance of memories, thoughts, feelings. So again, kind of trying to check out as much as you can. And if you think about it, a lot of our support groups or systems are in the place where the trauma have happened, right? So often we see clients as being resistant or don't want to engage in treatment when really they're probably just avoiding due to their post-traumatic stress. And just changes in cognitions and moods. So persistent negative beliefs about yourself, others, world, distorted cognitions, again, feeling that detachment from others. So, and after perinatal loss, so we know that individuals can have different trajectories, right? So how individuals are going to respond to trauma, again, depends on a lot of different individual factors. And it's the same kind of shows up in perinatal loss. So we know that women and men are at risk of experiencing post-traumatic stress after perinatal loss. To look at it holistically, we also know that they can experience post-traumatic growth. So post-traumatic growth is this idea that, or a theory, that there can be a positive psychological change after adversity. So this is a simplified schema of the whole theory, but this is kind of the focus of my research, so I'm going to go through this. But the idea is that when something traumatic happens, it really changes. It's not just about how stressful it is, so that the stress, but also how much it changes your core beliefs. So with perinatal loss, it has a huge potential for shifting your core beliefs because nobody believes that babies should die before their parents, right? So it kind of rocks our assumption that we have about the world or kind of how the life should progress, right? How it should unfold. So when that happens, individuals might experience those intrusive ruminations. So kind of like I just said with the PTSD diagnosis or post-traumatic stress, you will experience those very intense intrusive thoughts. We sometimes talk about it as stuck points, right? So over and over, people will replay that moment of trauma in their head. So oftentimes it's when they found out, right, the diagnosis, right, that sonogram, or when things, when they start bleeding or things like that. So that would kind of be involuntary, if you will. But then the idea is that once you start talking to others, talking about your loss, maybe you find a peer mentor, therapy, any place that you can get that positive social support, your thoughts will change into more deliberate. So you will start actually be more mindful about your thoughts and start making meaning of what happened. So it's not just that kind of uncontrollable flooding of memories, but also trying to start making sense out of what happened. So through that, you will experience this new changed narrative, be more resilient, have better coping skills or bigger repertoire of coping strategies, more compassion, and acts of service. So meaning, wanting to go give back to community, right? So somebody helped you, now you want to give back and also offer that help to others. So that's the theory. So in my research, I'm trying to test if that theory applies to this population. But so just a couple more things on post-traumatic growth. So there are 5 categories or domains that people can experience growth, and that's in new possibilities. So seeing like how you value your time and maybe reprioritize time commitments, seeing what else can be accomplished, that kind of thing. Your personal strength, being better able to handle any setbacks that you might experience, more wisdom, maturity, appreciation of life would be, just greater attitude, gratitude, sorry, not attitude, greater gratitude, hope, kindness, leadership, increased relationship with others, and then spiritual change. So either reevaluating your spiritual beliefs or your spiritual beliefs allowing you to reconnect and kind of reestablish those beliefs that you have about the world. Okay, so in my research, I was interested how those 2 outcomes between post-traumatic growth and post-traumatic stress or post-traumatic stress disorder, what's the relationship between those 2 outcomes, especially in that first year after loss. So oftentimes we think of those 2 outcomes as kind of on 2 separate trajectories, right? So either somebody lost their baby and they're doing well and they're resilient, or they're very distressed and that's the kind of at-risk population, if you will, that we need to treat, right? So I was wondering actually how that relationship happens and how it forms over the first year. So in my first study, I'm going to present a couple just so you know. So in my first study, my hypothesis was that there's going to be a bidirectional relationship between post-traumatic stress and growth at all 3 data collection points. And that also there's going to be a relationship, that relationship is going to be stronger for women who have history of trauma compared to those who had single traumatic event. So the idea is that if somebody had experienced loss, they're going to have higher levels of post-traumatic stress given their previous history of loss. So thinking at a population that potentially experienced trauma during that time have already experienced trauma in the past, right? So through either childhood trauma, sexual trauma, intimate partner violence, things like that, right? So I was wondering, because we have this kind of cumulative effect of it, right now we have multiple kind of trauma stacked together, that population will see stronger effects than just those who experienced single traumatic event, which was perinatal loss. Okay. So for my method, so I was looking at people, over 18 years old, who live in the United States, who had no history of perinatal loss or infertility, and they just had their first ever loss in the last 3 months. And they had no previous diagnosis of PTSD, and that was their self-report. So again, I was trying to see, like, in that first ever loss, how they navigated that. Okay, so just some of my measures. So this just, it just recently got published, so I can give you more details on if you're a little data nerd or methods nerd. But my timeline was, so we basically assessed how post-traumatic growth, post-traumatic stress and rumination, and social reactions. So social reactions, let me explain that one. So social reactions is basically when you disclosed your miscarriage, how did people respond to you, right? Did they respond in a positive way? Again, saying, wow, that must have been so traumatic. Let me take you to the hospital. Let me do your dishes so you don't have to, right? Or I'll take care of your other kids so you don't have to, right? So those would be positive social reactions. Okay, so I look at, the timeline was looking at 3 months after loss, 6 months after loss, and then again at 12 months afterwards. So we have 3 data collection points. And my participants, okay. So the final sample was 219 participants. I was excited that the sample was fairly racially diverse, not as much economically diverse, but as majority identified as middle class. And over half participants did meet criterion A for PTSD, meaning that they have experienced trauma in the past. So most of them endorsed having experienced car accidents in the past. so a single traumatic event. In terms of loss context factors, a majority of them experienced miscarriage, but there were some who also experienced stillbirth or termination of pregnancy for medical reasons. The average gestational age at the time of loss was 16 weeks. Majority did not have living children. And then I asked them 2 questions. So I asked them, on a scale from 1 to 9, how strongly did you feel like your pregnancy or fetus was a baby? And the average was 7. So most participants believed that their pregnancy was a person, so they identified it as a person. And on the same scale, how traumatic would you rate your experience? Again, it was 7 out of the highest being 9. So again, majority thought it was a fairly traumatic experience for them. So looking at the results, so overall in my sample, I saw very high levels of post-traumatic stress symptoms that did decrease from each data collection wave, but at 12-month mark, at 12-month mark, their levels of PTSD were still above the clinical, what we would consider above clinical cutoff, meaning that majority of my participants at a 1-year mark still, if they went to see a clinician, they would be diagnosed with PTSD based on those scores. So very high levels of trauma, despite that kind of decrease over the course of the year. And post-traumatic growth also changed throughout the year, with it being strongest in that first 6-month period. What you see on this very complicated graph is what it shows basically is that we found post-traumatic stress to act as a predictor of post-traumatic growth. So at each data point wave, so how they responded at 3 months with their stress predicted how much growth they experienced 6 months. And again, how much stress they had at 6 months predicted how much growth they experienced at 12 months. So it was related. Oh. Okay. So my kind of conclusions from this study were that perinatal loss population might be at more risk for distress compared to other traumatic events. I compared my data basically across a lot of different traumas, and especially when it comes to natural disasters, this population had way more distress, which makes sense, right? Because it's a more injury to your individual identity and disruption to your core beliefs, belief of others, and your future. This was interesting finding, definitely, that seeing distress as a predictor of post-traumatic growth, right? So again, not being two separate, on 2 separate trajectories, but being related to confirm their hypothesis. The other interesting finding that there was that high potential for experiencing post-traumatic growth in early months, rather than suggesting that those earlier interventions might be more beneficial rather than kind of waiting on later. And overall, that PTG or post-traumatic growth was a dynamic process that was associated with internal and external factors. So in my next study, I kind of wanted to know a little bit more about what are some of those factors that might be affecting post-traumatic growth. Oh, and in terms of, our second hypothesis was about the cumulative trauma. So we did not find significant results. They were trending in the way that would show that those who had multiple trauma would have higher levels of distress. However, I think because our sample was smaller, on the smaller side for this analysis, we did not find that significant. So that would be a definite point for future research. Okay, some clinical implications. So again, knowing that post-traumatic growth and stress can coexist. So as a clinician, thinking about post-traumatic growth as a component of post-traumatic reaction, rather than something that's inherent in recovery, that's just kind of, you have a lot of growth because you had a lot of stress, right? So it's kind of embedded in those 2 things. So being mindful as you're doing assessment, as you're talking with your clients or patients, when they're reporting a rate of growth, is it rooted in that high levels of distress as well? So it's screening being crucial, especially for women who have high allostatic load. So again, it wasn't quite significant, but I still think that it's population that we need to think a little bit more about if they are coming with multiple trauma levels and have that higher load to make sure that we are screening for trauma, for past trauma as well. And also, again, that crucial time for experiencing positive transformation. So the sooner we can intervene, the better. Okay, and providing basic safety, basic needs as a prevention for re-traumatization. So, I'm sorry, this. There you go. Okay, so looking at some factors of post-traumatic growth. So I mentioned rumination in the theory. So theoretically, again, intrusive rumination precedes deliberate. In terms of research, it's actually mixed findings. There's some positive relationships, some negative. So my goal in this next study was to just clarify the relationship, especially that was never evaluated in the longitudinal way. And I was also curious about the social support. So we know that your history of connectedness is a better predictor of your health than a history of adversity. So that's a quote from Dr. Bruce Perry, also a trauma researcher. But let us think in for a second, right? How your history of connectedness is a better predictor than your history of adversity. So kind of no matter how terrible things have been in your life, how terrible traumas you have experienced, if there was at least somebody, one person in your life that was there for you, excited for you, rooted for you, that would change your mental health and health outcomes in the long run, right? So human interactions are very meaningful, very powerful, which for a clinician, right, that's exciting to hear, right? That really the connections and safe space that we provide for our clients, it really matters. The only previous study that looked at those positive social reactions, right? So again, like I mentioned before, right, there's a lot of still stigma, and the responses that we're individuals who experience loss encounter might be counterproductive, if you will, right? That might be actually negatively impacting individuals. So I was curious what's that relationship to post-traumatic growth when you do have those positive social reactions? And how does that impact your rumination? So that was actually part of my dissertation. So I did find that relationship, but it was, again, just one point in time. So I was curious to see how that looks over course of time. So for my second study, this one just got accepted for publication like 3 days ago. So it's coming. But so my hypothesis was that intrusive and deliberate rumination and social reactions at the first wave, so again, at those 3 months after loss, will act as a predictor, and those at the 6 months will predict deliberate rumination at 6 months, and that the relationship between social reactions at 3 months and post-traumatic growth at 6 months will be mediated by those two types of intrusive rumination. Okay, so hopefully I know that's a very long hypothesis, so hopefully that will become clear as we go through results. So again, a scary table, just if you're like that kind of things. But basically what it shows is that at intrusive rumination and social reactions did predict deliberate rumination at 6 months, but not at 3 months. So I guess our hypothesis was partially supported. So we saw some relationship at 6 months, but not at 3 months. And then another scary graph. We found, so basically this whole model, we found it significant. So basically shows that there's a positive mechanism between social reactions at that first wave, so 3 months, and post-traumatic growth at second wave that was mediated by intrusive rumination. So basically, if you think about it, what people said to you right after your loss still mattered 6 months later in terms of how you were thinking about it and how you experience your growth. So when I think, again, as clinicians or people who work in this field, we intuitively know that, right? But now we have data showing that like it really matters how you talk to somebody after they experience loss, because it shows up and their ability to process that trauma. Okay. So again, those two types of ruminations likely co-occur. And rather than it being linear going from one to the other, there's probably some back and forth, right? So your clients or patients might experience some mixture of both intrusive and deliberate rumination as they're trying to navigate this loss and process it. Because there's that lack of temporal association, continuous assessment is required, right? So again, checking if somebody's reporting that things are starting to click, but they might still also have those intrusive thoughts, right? So making sure that we're still looking at kind of both sides, if you will. And then the importance of supportive responses, right? And this and long-term access to social support. So that's one data that I didn't mention, that overall, not surprisingly, over the course of the year, participants reported declining levels of social support, right? So again, showing that having that social support is important to be able to have somebody talk through those ideas or your processes, how you're making meaning out of it, especially again, knowing that majority, at least in my sample, think of a loss as a person, right? Thinking about that, having that conversation with your clients. How did you thought about your pregnancy? And then I know continue to breaking the stigmas, right? So we have more open conversations about this topic, and there's not so much shame associated with it, and psychoeducation to support system of what they might see as their loved ones navigate this loss. So additional reminder, especially for clinicians in this room, by nature, a traumatic event is characterized by feelings of terror and crippling disempowerment. So clinicians must ensure that their clients do not experience therapy in the same way, right? So thinking, even if you're not a clinician, thinking in a hospital or any setting that you work in, how can you minimize potential for re-traumatizing your clients in those settings, right? As the way that they don't have to come to a follow-up appointment and be in the same room with that they've been before, right? Or been surrounded by other pregnant people. So what are some ways that we can reduce that feeling of terror and feeling like I'm out of control, out of power in those settings? Again, just a general reminder of what traumatic assumptions people might have after trauma. So I'm not safe, right? I'm not safe. People want to hurt me. The world is dangerous. If I'm in danger, no one will help. I'm not good enough, smart enough, worthy enough for people to care about me. I'll never get better, right? So what can help traumatized individuals survive? There's some danger, right? If nobody's going to help you, I don't feel safe, I'm just going to assume that that's the world I'm in. Being able to quickly mobilize when there's some sort of perceived threat, and it doesn't have to be real, it's just perceived, right? Something that again activates that stress response. Self-protective stance, and so with all those three things especially, right? Again, as you're thinking about your clients, that how they're engaging in your services, how they're coming to see you, I feel like a lot of times that might be misperceived as, again, being resistant. They're so aggressive, they don't want to participate, when really is a trauma response, right? They're responding to trauma that is impacting how they're thinking, how they're communicating. So just a reminder. And then some other ways, that can meet developmental needs: self-injury, substance use, reenactment of traumatic events. So additional key triggers for traumatized individuals to keep in mind: lack of power of control, unexpected changes, feeling threatened or attacked, feeling vulnerable or frightened, and feeling shame. So again, as I'm going through this list, think about in your settings, how are you providing more power and control for your clients or patients? How can you reduce that feeling of unknown from one procedure to next? How are you making sure that they're actually participants in their care, not just being told what to do? So lastly, What do trauma survivors need? Again, to feel safe, feel in control, express their emotions, and know what comes next. So again, thinking about how can you foster that in whatever setting that you're in right now. Okay. So we have a few minutes left. So I have one last thing that I want to talk about. So now that we know, like in that first year, a lot can happen, right? In terms of somebody's mental health as they're trying to navigate it, they're still processing that experience. And yet we know that a lot of people will get pregnant again, right, within that first year. So thinking about how that might impact then that relationship with the subsequent live birth and individuals' postpartum mental health. So that was kind of where my next thought was in terms of what is important for us to know. So first, as you might be aware, we are facing maternal mental health crisis in this country, as well as maternal mortality crisis. So I'm from the state of Missouri, so those are Missouri statistics. But unfortunately, I know that they're probably similar wherever you're coming from. So we have a very high mortality ratio in the state of Missouri, and majority of the deaths happen in those 43 days to 1 year postpartum. So it's, again, not that initial period right after, but much later, actually, as individuals are transitioning to work or transitioning, changing feeding strategies and things like that. And then, unfortunately, in our state, 80% of those deaths are preventable. So I guess good news, because we can prevent it, bad news that we haven't prevented them. So leading cause, again, in the state of Missouri, have been shown to be mental health conditions. So 59% depressive and anxiety disorders are responsible for those preventable deaths that we are seeing. So how does that relate to perinatal loss? I wanted to look specifically at perinatal loss, again, because of that statistic that 50 to 80% of women become pregnant again within a year or so. But also we know that those who had perinatal loss, they are at higher risk of perinatal mood and anxiety disorders already. And that loss impacts your self-perception, right? So we know that, I mean, motherhood is highly valued in our society, right? So when that loss happens, it brings a lot, it can have a profound impact on somebody's identity, right? Now that I'm not a mom, or I can't be a mom, who am I in this society? How do I function? So despite this being a crisis right now, there's really no studies that are exploring mechanisms driving postpartum anxiety. So having that in-depth understanding, what is really, how is it developing in this population, even though they're at higher risk, we have no really context of knowing the mechanisms behind it. And if untreated, we know there's a severe impact of untreated postpartum anxiety, such as worsening comorbidities, adherence to medical regimens, worsening finances, substance use disorders, suicide, and at times even infanticide that can happen. So in my research, I picked two factors that I thought that are most likely to contribute to postpartum anxiety. So looking at that maternal self-esteem, again, from anecdotally or from clients, hearing that as you're experience that loss and now you're parenting, there's more of that blow to your self-confidence, basically, right? Because you have your increased self-doubt in your ability to parent. So always questioning, like, am I good enough mom, right? Because I mean, I let my first child die, right? Which is not true, but that guilt is still there. And rumination, right? So as you saw my previous research, I thought those ruminative thoughts will be driving postpartum anxiety as well, which can impact your ability to attend to or respond to infant cues, right? If you're constantly kind of in your head thinking through all those bad things that happened, you can't effectively engage in parental problem solving, and it might reduce your bonding with infants. So for my third study, so it's a separate data collection from those other two. I looked at 400 women who within the first year postpartum, who again had that history of loss. So I collected data in 3 different ways to better understand this phenomenon. So first, I used cross-sectional data. So I looked at individual self-esteem. So I basically asked them in the online survey about their levels of self-esteem, self-competence, the level of bonding with the child, the level of anxiety, and rumination. And then I also collected data, intensive longitudinal data. So for 14 days, I was asking them every day, tell me your level of bonding. How bonded do you feel with your child today? How anxious you're feeling today? And how much are you basically thinking things over today? And then I also asked them, what are your specific ruminative thoughts? What is that specifically you're ruminating? With my hypothesis being that they're all going to be death-centered, right? Since that the worst have already happened, we're going to be constantly thinking about the worst thing happening again. So some key findings. I'm still processing this data, so I'll be honest. There's a lot of data that I'm going through, sifting through. But just kind of what I'm finding so far that I wanted to share with you. I do find high levels of anxiety, which do impact bonding with infants. So there's that relationship that anxiety is creating a challenge to be able to bond with an infant. And that previous loss experiences, again, how severely traumatic you perceive that loss to be did relate to postpartum bonding. And in all of that, so all those factors that I was looking at, so trauma, self-esteem, self-competence, rumination, they all predicted postpartum anxiety in women who had history of perinatal loss. So I still haven't had a chance to map out this daily things, but my hypothesis is that, again, as you're being more anxious, that will your ruminative thoughts will increase your anxiety, and that will reduce your bonding, right? So if you're thinking all day, I'm gonna drop the baby, then you're not gonna interact with your baby as much, right? Because you're afraid they're gonna drop the baby. So then that's gonna make you more anxious, and then impact how much you're interacting with the baby. So that's the relationship I'm expecting to see based on some previous research and kind of what I'm seeing in the literature in my data so far. Then looking at the qualitative data, so far, those thoughts are centered on physiological and psychological safety of both mom and an infant. So again, being scared that they're gonna drop the baby, that they're gonna poison the baby, that they're gonna, I'm trying to remember, that the mom was not doing enough, not feeding the baby enough, that kind of things. So again, this is just a little introduction. I'm hoping to process the rest of the data and distribute it soon. But thank you so much for listening. I saw some questions coming in. I'm happy to have a discussion and kind of get your feedback on what you're thinking and what you're seeing in your practice. So if you have any, if you want to connect afterwards, this is my email address. So again, I'm at the University of Missouri, St. Louis, where I'm assistant professor. So I would love to continue a discussion, but I'm going to start sharing now. And
Thank you so much, Dr. Freedle. It's really exciting to see the research that you're undertaking, both for clinicians and for the range of people that intersect in their professional roles in the ways that we can respond, but also anticipate over a long period of time so that the loss families don't fall off the conveyor belt when they're done with their medical care. So I'm going to open up for questions, but I need to be able to see everybody. Please feel free to come back on with your video and either pose questions in the chat or raise your hand and I'll call on you. So Dr. Freedle, we have a question from Allison Baker. Your findings really resonate with what I see with my clients, and I think this information will be very validating for them. From Josephine, for your third study, did any of the participants have living children? I think she means before the loss. I wonder if having living children at home made a difference in levels of anxiety or an ability to bond with the new infant.
Yes, definitely. So for this the third study, I wasn't as strict in terms of, this being your first loss or anything like that. So there definitely was a split in terms of when they had living children, whether it was before or after the loss. So I haven't done that detailed analysis yet, but I could see that can impact that as well in terms of just having more on your plate, right? Because if you have more children to take care of and be anxious about that. But overall, we see having living children as a protective factor. So if you do have living children, the impact of this loss is not as disturbing, I should say, or distressing as it is when you don't. And I think part of it is because I think if you don't have any living children, then there's like question like, what is my reproductive story going to unfold, right? Like, am I ever going to be a mom? Am I a mom? Where am I? Versus like when it happens after you have living children, there's a little bit different perception of self. That would be my. Thank you.
And from Emily, who's with Bereaved Parents of Madison. Thank you very much. I'm involved in direct and group peer support for families after perinatal loss. What advice or suggestions do you have from your research that could help us talk to providers and convey the importance of peer support?
Peer support is so important. So thank you for doing this work. It is. So again, like if you're thinking about this post-traumatic growth theory, right? And just what I'm finding in my research, that individuals, because there's so much stigma in our society, they really, unless you've been through this loss, you don't really understand, right? It's kind of like you don't really get it. So being able to have that mentor or peer support, again, somebody who's been through where you are and kind of understand how it feels when people are telling you those things that are, again, like not really comfort. They're meant to be comforting, but they're really not, right? I think from my research, what I just shared, I think having that earlier on, or being able to connect individuals to peer support earlier on can foster that growth and reduce that distress basically earlier, right? So the finding basically from the second study would provide some support for that argument, as well as again the second study where like what people told you matters, right? It changes how you're thinking, like it changes the nature of your thoughts. So I think the earlier we can foster those connections.
I wonder also if you can comment on things that the medical providers can do to welcome their patients as they return for postpartum checkup, and then whether they maintain a relationship with those providers. What are the ways in which they can shield them from re-traumatization?
Yeah, so I think knowing the history is important, right? So we don't accidentally ask like, oh, how's your baby, right? When the loss happens. So obviously knowing the history, knowing what you're walking into. If possible, doing screening or just checking, right? How you're not just doing physically, but also mentally. I think it would be helpful as a mental health provider, like having that more of a like, connection, right, between the two worlds, so we can have a more seamless referral system. So we can better support, again, not just physically, but mentally as well in that space. So I think just providing that space, or even checking in or screening if possible, for some of those trauma responses, trauma reactions, depression, anxiety. Yeah.
Thank you.
Yeah. Good questions.
I don't see, so I'll just keep coming up with questions while we have time to have you here.
Oh, and I'm just going to respond to the earlier one. So I will send the slide deck after the presentation, so you will have access to that. So
Great, thank you.
I was tweaking it last minute, so I wasn't sent in advance.
Absolutely, absolutely. And what about people who are seeing families in the hospital or medical setting in subsequent pregnancy, and and what your thoughts are about them acknowledging that this is the baby after a loss
Mhm.
in their interactions with the families.
From a family standpoint or the providers? Sorry, I
From
missed
the,
that.
so not necessarily the birth provider, but nurses that see them when the
Mhm.
patient is in the hospital, or nurses that, and assistants that room them when they're in the doctor's office, about they're there for a pregnancy. And what are your thoughts
Mhm.
about them acknowledging explicitly that it's the pregnancy after a loss?
I see, I see. Okay, I understand. So not in that when that loss happens, but after. Yeah, I think um, again, knowing the history, or at least asking if it's not in the file, um, supporting what would be helpful. Well, so again, like if somebody have experienced trauma, the trauma is basically not feeling safe in your body, right? I in that situation, I had no control over my body, over my circumstances. So how can we not create the same situations, right? So can we do those little things, like making sure the lighting is the way the patient or client wants, right? And whatever the setting is, can they have a choice of how they want the um, how frequent they want to be checked or not checked, or just having empowerment over or control and power over their own body, right? Not asking them to put their body in a compromising position, especially if there's a perinatal loss or if there's sexual trauma history, right? How can we minimize that feeling of vulnerability? Can we minimize the amount of people that are in the room? Or if there are multiple people in the room, can we make sure they're being introduced? And are you okay if the medical student is also here? Are you okay if the resident is here? Um, so again, providing some of that control in the situation and safety in that.
Great, thank you. Mary Grace asks, as a chaplain, I wonder what spiritual themes you saw in your study.
So it's interesting. So post-traumatic growth, one of the domains is spiritual domain. I have not looked specifically at the domains, and especially the spiritual one. They just recently redid it because there's some problems with the scale, to be honest. So they've been trying to see how can this spiritual growth be adequately captured. So I have not looked at it specifically, knowing that the scale might not quite accurately capture that. But I am setting up a new study right now, actually, where I will be looking at individuals' attachment to God and how that impact their processing loss. And I'm looking at that because I think it's so interesting that there's a lot of ambiguity in terms of knowing what happened and how even my child is being viewed through that kind of religious or spiritual lens, right? So is my child, if you're, Christian, like is my child an angel? Is it not? Is it, is it going to heaven? Sin if there was no, or heaven or hell if there was no baptism? How does that look like, right? So I think for a lot of different cultures and religious and spiritual beliefs, there might be that kind of ambiguity. So I'm so interested in how that might have changed, or how that attachment to God might have been changed as the process. So I guess stay tuned. I'm not sure yet. So I'm just in the process of collecting data for that one. Yeah, but I do think it's very important team.
As a clinician, and we do have clinicians here, I'm curious if you can just talk for a moment about the therapeutic. I read in your on your website, Dr. Perry's model of
Mhm.
intervention that you're looking at working with.
Yeah, so that's the trauma background or training that I have is a neurosequential model of therapeutics by Dr. Bruce Perry. So it's a way that you conceptualize clients who have experienced trauma to make sure that you're considering developmental and neurological changes that have happened. So using that neurobiological lens to understand the behaviors that you're seeing. Because clients who have experienced trauma, they really do present in a very complex way. And that it can often be it can be misunderstood, right? Like I said before, like as being seen as angry or resistant or non-compliant or overly compliant, right? When truly those are how you learned as a result of this trauma to navigate the world so you can feel as safe as you can, right? So when I was going over those tenets of trauma, right, that's kind of how you adapted to make sure you survive. Those survivor strategies are not working, right? And as a therapist or clinicians, we will help you kind of recognize kind of how to re-regulate your nervous system. But acknowledging that so the focus is on understanding kind of those how trauma basically changed brain functioning and how it's being seen, and so understanding that complexity to reduce misdiagnosis. So we're not saying that it's ADHD or other things, but it is all stemming from traumatic experience. Yeah. So that's the NMT.
Thank you. That's helpful to put your narrative aspect of that and how it connects with what you've been talking about.
Yeah. So as a clinician, like before I worked with perinatal loss specifically, I worked in trauma in general. So a lot of kind of that. Continue to kind of utilize those both backgrounds in my research. And
we've got some, this was a great webinar, thank you. And you all have Dr. Freedle's email, should you want to pursue any further questions that you have. Thank you all for attending. Those of you that are members of PLIDA, hope that we'll meet you at the conference in May. And now we're getting a stream. Dr. Freedle, you can see thank yous.
Thank you.
So please feel free to investigate more about PLIDA and our upcoming webinars. We also have some crossover with Resolve Through Sharing, which is going through some transition, but there's some offers for membership for PLIDA members to have new memberships, and vice versa, RTS training to have new memberships in PLIDA. And feel free to reach out to PLIDA organizers through our website. We have an Ask PLIDA for questions you might have that I'm on the committee that respond to that. There's the membership committee that responds to membership questions. If you have ideas about webinars that you would like to see or you would like to present, also feel free to contact the contact person on our website, and we will get you linked up with those who are organizing that. So thank you all and have a good afternoon. Thank you very much, Dr. Freedle, for this very interesting and satisfying webinar.
Wonderful. Thank you so much.